Hello and welcome to the DeSera Clinical Education Oncology Podcast. I'm your host, Sharif Mursala. Today's podcast features Danielle Roman from Allegheny Health Network and Jordan Hill from the West Virginia University Cancer Institute. They'll be sharing their insights on patient-centered management of CDK4/6 inhibitor therapy for HR-positive, HER2-negative breast cancer, with a focus on adverse event management, patient education, and adherence strategies in clinical practice. For more information on our presenters, along with a link to the full educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
Thanks for joining me for this DeSera Clinical Education podcast on patient-centered management of CDK4/6 inhibitor therapy for hormone receptor-positive, HER2-negative breast cancer. I'm Danielle Roman. I'm a clinical pharmacy manager and clinical pharmacy specialist at Allegheny Health Network in Pittsburgh, Pennsylvania. And I'm joined by my colleague, Jordan Hill.
Hi, thanks for joining us. I'm Jordan Hill. I'm a clinical oncology pharmacist at the West Virginia University Cancer Institute in Morgantown, West Virginia.
We're here today to discuss some of our experience with managing CDK4/6 inhibitor therapy. We're going to talk about all of our 3 CDK4/6 inhibitors today, but really focusing in on the 2 that we are using in the early stage breast setting now, ribociclib and abemaciclib. So we're going to first kick off with some discussion of toxicity profile, management strategies. These drugs are certainly not benign. So there's a lot to talk about here, a lot of kind of unique toxicities that we can see with these agents. So we'll kick it off there. And really I'd like to highlight that as we use these agents, early identification of toxicities is incredibly important. We have a lot of structured management strategies that we can utilize if we know about the toxicities. So really close monitoring is incredibly important and something I think you'll see as a focus. But we'll first start with just an overall discussion of some of the key adverse effects that we are monitoring and managing with this drug class. So a couple of the key ones to highlight. Diarrhea is something that we can see with all of these agents, although it is one that we see more so with abemaciclib. And that's a toxicity that we'll be highlighting further as we continue in our discussion. Hepatobiliary toxicity is another one, important one with abemaciclib and ribociclib. We see it much less so with palbociclib. Neutropenia is another one we'll be spending some time on, something we can see across the board with all 3, abemaciclib, ribociclib, and palbociclib. It requires strict monitoring strategies. A mention of VTE is something that is in the prescribing information as a warning with abemaciclib, so it should be a counseling point for patients receiving abemaciclib. ILD or pneumonitis, there is an FDA warning that came out with this drug class, so all 3 of our agents. We should be monitoring for changes in pulmonary status that may indicate ILD or pneumonitis, so things like hypoxia, cough, dyspnea. It is an uncommon toxicity, but certainly one that should be on our radar with these drugs. And then finally, we'll have some discussion on QTc prolongation, specifically something we see with ribociclib. Now, in terms of the toxicity profiles with these agents, we mentioned abemaciclib. Diarrhea is a very common toxicity, so it is usually the toxicity that we think about when we think about this agent. So early use of loperamide, hydration, dietary modifications are very important. With ribociclib, QTc prolongation and increases in LFTs are important monitoring points. We can also see increases in LFTs with abemaciclib. And then I mentioned the hematologic toxicity is something that we can see as a class effect with all of these agents. Palbociclib and ribociclib do tend to have more of the neutropenia effects compared to abemaciclib, which tends to be less severe. So we're going to first focus some of our discussion there in the monitoring and management of neutropenia. Patients on CDK4/6 inhibitors should have close monitoring for this side effect. This would include a CBC with differential before starting each cycle. And because this is an early toxicity, it's recommended to have extra assessments in the first 2 cycles. So generally about halfway through the cycle, we should be doing some extra monitoring, particularly if those first 2 cycles. Patients that are stable often don't need this beyond those first couple of cycles. If patients have grade 1 or 2 neutropenia, so this would be an ANC of 1,000 or greater, we can generally just continue therapy. So no need for any dose reductions or extra monitoring at this point. For those with grade 3, this would be an ANC between 500 to less than 1,000. As long as there's no fever, which is, most patients are not going to be presenting with fever, we would hold the dose and then close monitoring of the counts. Once that ANC resumes to at least 1,000 or greater, we can continue at the same dose level. Now, if these patients have recurrent grade 3 neutropenia, this is a point where it would be helpful to consider and is recommended to consider dose reductions in that setting. And then in the rare situation where this may be accompanied by a fever or in a patient that has an ANC that's grade 4, less than 500, it is recommended to hold the dose, watch counts closely, and then once that ANC is at least 1,000, resume at a dose reduction. So the good news about this is while we see this commonly, this side effect is generally reversible. So holding therapy, we usually get improvement in the counts. So just something that I think is kind of an important point as we talk through this. Now, I'm curious, Jordan, if you could maybe share some of your experience with maybe some of the challenges surrounding monitoring for neutropenia.
Of course. So, as you mentioned, with the mid-cycle monitoring, those first couple of cycles, that can be extra either visits. And so, typically, what we'll try to do is those mid-cycle day 15 labs, and then we sort of review those in the EHR. And then the start of each cycle is typically when we are seeing them here in clinic. That works well when they're being used in combination with aromatase inhibitors alone, but it can be challenging if it is a patient who is also requiring an LHRH agonist because sometimes the injections don't always line up with the exact beginning of the cycle, depending on when those were initiated. And so sometimes that does require some logistics workarounds to kind of get to where we're seeing them on the days of their injections, but then ensuring that their lab monitoring is still occurring at the appropriate time points. So just thinking through how to make it most convenient for patients to really ensure the monitoring is happening when it needs to occur, especially during those first couple of cycles. Like you mentioned, after those first couple of cycles, most patients are okay to just do once per cycle. So even if it doesn't line up exactly right, it's usually easy to maneuver around. I will say with the agents that you discussed as having more neutropenia and ribociclib and palbociclib, we do often have to do some holds, especially in the metastatic dosing of the ribociclib, less so with the early stage dosing. And so sometimes that can complicate things too, because even if you think you have their injection appointment and their clinic appointment lined up, then you end up holding and restarting their cycle at a delayed time. And so that can adjust the timing some too. I will say to your earlier point about it is, very reversible. They do resolve pretty quickly, and we're able to usually restart that following week. And then if it does recur or it is a higher grade and we do that dose reduction you mentioned, I do typically see that to be very effective. Usually once we do those dose reductions, it works well for patients. Very rarely we will change somebody to abemaciclib if we're really struggling with counts from one of the other two. But we do, on very rare occasions, struggle with the early stage setting where they really only qualify for ribociclib and we're struggling with those counts. So, it is potentially something that could be discussed about doing some off-label. Do you give them 2 weeks off? If they're already on the lowest dose, ribociclib is the only one they qualify for. So there are some things that we could consider, but that's usually the trickiest scenario is an adjuvant patient who really only qualifies for ribociclib, is already on the lowest dose, still having struggles with neutropenia. Do you continue to hold it every single cycle? Do you just say, we're just going to do a couple of weeks off? Do you discontinue the drug? Just different things that are very patient specific. That is probably one of the more challenging, although not common scenarios that we see. And then I do to to your earlier point about making sure patients know exactly what to expect earlier on is very important. So if you could share what sort of counseling points you provide to your patients to ensure that they are well educated and prepared for the recommended monitoring.
I think really highlighting in your early patient education that the neutropenia is common and the importance of those lab draws and that close monitoring, particularly early on. Another point that's really important is while the neutropenia is common, we don't often see infections or fevers associated with this. So I think that's a reassuring point for our patients, but really also is just still making sure that they know that this is something that we need to monitor. We may need to intervene. I think kind of setting the stage early on, that the fact that it's fairly common that we may need to hold for a little while. Dose reductions might be necessary. And I think kind of emphasizing that point early on can be really helpful in ensuring our patients are going for those labs in a timely manner. To your point of trying to make this as convenient as possible for patients, I think that is a really important point too. And we're often trying to schedule things to help line up visits for them. It is very difficult to, at least from my point of view, for us to get labs on day one of the cycle because those scripts often need to be sent in advance to a specialty pharmacy for filling. Sometimes the timing of those labs to make sure that we are making decisions about dose at the time we're sending the script out are really important. And sometimes, we need to talk through that timing and figure out what's going to line up best for patients. So I think those are some strong points on neutropenia. Certainly the most common toxicity that we're going to talk about today. But another one I think is a really important one to highlight is that hepatotoxicity. So kind of sticking on the vein of lab monitoring and what we need to do for our patients. So this is something we can see with abemaciclib and ribociclib. I have seen it with palbociclib, but it is not as strict monitoring, at least in the PI, and certainly the frequency of seeing this side effect with palbociclib would be a lot less. So we'll focus on abemaciclib and ribociclib here. But Jordan, I'm wondering if you can share a little bit about the hepatotoxicity and what in particular we need to monitor and how we might manage this.
Yeah, of course. So with hepatotoxicity from either abemaciclib or ribociclib, they do usually recommend that mid-cycle monitoring, those first couple of cycles, similar to what we discussed with monitoring for neutropenia. And then after those first couple of cycles is where it gets a little bit different between the two agents. So thinking about abemaciclib first, after those first two cycles where you're going to check it at midpoint of cycle, then it's monthly the next two cycles, and then as clinically indicated after that. I will say this can occur quite late sometimes, and even from the median onsets that we saw in the trials, it's not always within those first four cycles. So we do typically continue that monthly monitoring even after those next two cycles. But per the PI, it's just kind of as clinically indicated after those first four cycles. Um, and then even though it does have those close monitoring recommendations, I do typically see it a little bit less frequently than I do with ribociclib, but it is still something that's very pertinent to be monitoring for and keeping an eye out for. That way, as you mentioned earlier, that early identification, making sure that if we are starting to see the LFTs rise, that we can appropriately manage that. And so with abemaciclib, what we usually will recommend based off of the labeling is that if they are at a grade 2, it's not needed to like hold or dose reduce at that point, but those are people that I'm monitoring closer. That way, as soon as it hits the grade 3 and the labeling wants us to hold until it resolves to a grade 1, we can do that. And so those patients that are getting to grade 2, I typically recommend a little bit closer monitoring. But per the label, as long as their Billy is normal, you really don't have to hold until they get to grade 3. But at that point, you would want to hold. And then once they resolve, you would dose reduce. And then Kind of similarly with ribociclib, the monitoring schedule is going to look similar at the beginning. The every 2 weeks, first 2 cycles, beginning of each cycle, they recommend for the next 4 cycles, so a little bit longer. But again, our practice is to continue doing them monthly, just in case we do see a late onset hepatotoxicity, we're able to catch it. And then with ribociclib, they do recommend holding a lot sooner. And that's really to try to prevent those higher grade elevations. As in my experience, LFTs can get quite high from ribociclib. And additionally, they really can take a while to recover. And so, if we can catch them earlier and hold sooner, hopefully they don't get as high and they don't take quite as long to resolve, which maybe in the early stage setting is not as concerning. They don't currently have any disease, but can be quite problemsome sometimes in the metastatic setting if you're really having to hold for a long time in somebody who does have active disease. But for ribociclib, you would want to hold at a grade 2 in the early stage setting. Sometimes different clinics would even recommend thinking about holding at a grade 1, just to ensure it doesn't get higher, and you don't have to hold very long, but definitely by grade 2, you want to definitely start holding, letting it resolve, and then technically resume at a lower dose. The labeling does recommend that you resume at a lower dose, but in my experience, I do see it recur sometimes even at that lower dose because it's not necessarily a dose dependent side effect. So that's something that I do think is probably a little bit clinic and patient specific as well.
Yeah, so thank you, Jordan, for sharing that. It's good to hear that your practice mirrors a lot of what I see in my own practice. So I think, you know, we do monitor, even though the PI really after those first, 2 to 4 months of treatment is a little vague in terms of the frequency of that LFT monitoring or when it's even needed. We do continue that throughout their treatment course, generally on a monthly basis. It's reasonable to space it out in patients who have been very stable for long periods of time. But knowing, unlike neutropenia, this is a toxicity that can occur later, I think it makes a lot of sense from a patient safety standpoint to continue monitoring that. And then to your point about whether you would restart at a dose reduction, that has been my practice, but I can see the argument knowing that this is a side effect that um, isn't necessarily dose dependent, that we can see this recur even on lower doses. Think you could have an argument to continue, particularly in the curative setting, if you're looking to maintain that. But in my practice, we have more often dose reduced with that. I think just following PI and, out of concern for sometimes the degree of hepatic impairment we're seeing.
Yeah, I agree. We've actually retrospectively went back and looked at hepatotoxicity in our patients taking ribociclib and found that our rates of grade 3 are pretty similar to what they were in the trials, but the rates of grade 4 were still less than 10%, but I mean much higher than what was reported in the trials, which is, that like 1 to 3%. And so we do get a little bit nervous with grade 3s. So typically with a grade 2, we're following the label, we're holding, we're dose reducing, and we're resuming. But with a grade 3, sometimes we'll just switch just out of fear that it's going to recur even at the lower dose. And that could be very patient specific, right? How high did they get? How long did it take to recover? It might not be the same for every single person, but it is something that we do consider for some of those grade 3s. Do we want to resume at the lower dose? Or if they are a candidate for another CDK4/6 inhibitor, do we just switch them over? As our discussion earlier, it can still happen with abemaciclib, so it can be tricky in that early stage setting where we don't have palbociclib as an option. I just anecdotally have had some patients that we did switch from ribociclib to abemaciclib in the early stage if they did qualify for both. and didn't see it recur. But in the metastatic setting where we know that palbociclib, even though to your point, it does still happen a lot less often, is probably the safer option, especially if you really had some high grade hepatotoxicity. But we do at least have a little bit of flexibility, which I think is a really exciting thing for our patients having, more than one option in both settings now.
Yeah, great points. I think another just kind of thing we always want to keep in mind, particularly on the pharmacist side of things, is ruling out other causes of hepatotoxicity. So we certainly know these medications can be major contributing factors to those changes in LFTs. But we also want to keep in mind other medications the patient may have started recently, supplements. I certainly want to ask about acetaminophen. That's one notoriously, if we have patients that have started that or taking higher doses, could be impacting what we're seeing, alcohol intake. So I think that needs to be a part of our differential as we're seeing these lab changes. But we do want to have top of mind that ribociclib and abemaciclib are often contributing factors here with those LFT changes. So we are going to move on to another toxicity, is an important one to highlight, and that's with abemaciclib-induced diarrhea. So we mentioned previously that we can see diarrhea with these agents, but abemaciclib is the one that does have this unique early onset diarrhea that we do need to have close monitoring strategies. Certainly something we want to counsel patients on. We want to make sure that they have antidiarrheals on hand and that they know what to do if and when the side effect happens. So for patients that are having a grade 1, so less than 4 stools a day over their baseline, generally we can continue, but with the recommendations for dietary modifications, increasing oral fluid intake, and initiating antidiarrheals. Once we get to the point of being a grade 2, so this would be 4 to 6 stools over their baseline, this is something, again, we want to be initiating antidiarrheals across the board, recommending those dietary changes in fluid intake. But here we're going to have really close monitoring of our patients. So we're going to watch that closely with the antidiarrheal. If we don't get resolution within 24 hours, this is the point where we would want to hold abemaciclib and monitor for resolution to grade 1 or less. At this point, it is possible per PI to restart the medication at the same dose. However, if patients do have persistent or recurrent diarrhea, grade 2 diarrhea, it would be recommended to dose reduce in that setting. For those patients with maybe higher grade diarrhea, so a grade 3 or 4, it's recommended to hold until diarrhea has resolved to a grade 1 or less, and then dose reduction would be warranted with restarting here. So important monitoring point, something we should be assessing for at each visit with a patient or each touch point with our patients, and making sure that they have an antidiarrheal on hand as they initiate the medication. I do want to briefly talk about the trade information. So this was a study that was presented recently. This was looking at dose escalation of abemaciclib. So there has been success in other TKIs in this strategy of dose escalation to try to improve that early tolerability. So this was particularly a trial of abemaciclib with endocrine therapy in those patients with hormone receptor positive, HER2 negative early breast cancer that are receiving adjuvant abemaciclib. So patients received a 50 milligram twice a day dose for the first 2 weeks, and then if tolerated, that was increased to 100 milligrams BID for the next 2 weeks, and then finally up to the full dose of 150 milligrams PO BID. And the trial here did show a statistically significant improvement in the endpoint, and so this was meeting that target dose of 150 milligrams twice a day. And so I think this presents us with another opportunity to help improve early tolerability for our patients. Jordan, I'm curious, have you initiated the trade strategy in your practice?
We have. I am excited about the data. Similar to you, I do think it provides a nice option for our patients. I will say it sometimes is a little bit logistically challenging, at least in my experience, because a patient either has the potential to have 3 copays within 6 weeks if you're sending it as 3 different scripts, or a pretty high pill burden if you're going to try to do the full titration with the 50 milligram tablets. So it does require a lot of education. But from the tolerability standpoint, it does provide a very nice option to try to mitigate some of that diarrhea and allow more patients to get to full dose. I will say sometimes what we do, just because of those logistical concerns, is we'll start at 100 milligrams. So still not at full dose, but the only two copays instead of three sort of thing. Because unfortunately, a lot of times we'll get issues with insurances covering the 50 milligram tablets. And so I try to get it to where I can limit the copays, but also improve tolerability in the best way I can. And anecdotally, I will say that has been very beneficial. We still see improved tolerability and ability for patients to get to and stay on full dose by doing it like that, even without the full titration. Patients that were more concerned about tolerability in will do the full titration. And so it just is a little bit dependent on the patient and how they present, what our concerns about their tolerability are, and then what sort of financial concerns we're taking into consideration. So a lot of education, of course, but it is a really nice option. What about your experience?
Yeah, I would say similar experience. I love how you brought up the challenges around that dose escalation because it's not the easiest thing to pull off in practice. Another strategy I have used on a few patients is just prolonging that escalation a little bit. So the challenge at the 2 week point and the scripts is real. So I think there you may have a little bit of flexibility to do that 50 milligram twice a day dosing for that month, and then go up to the 100 milligram BID for the next month, and then to that full 150 milligram BID. So I've done that strategy as well. I like your strategy of starting at 100 milligrams. I think that's also, it's kind of mixing our traditional practice with the dose escalation strategy to make it all work out logistically in practice. So I think that also makes a lot of sense. Yeah. Anything else that you want to share in terms of your experience around maybe patient counseling with diarrhea management? Anything that you're routinely instructing patients as they start the medication?
I think this is a really important side effect to really provide a lot of education on because of how common it is. So for most people, it does start early, as you mentioned, and it does improve, but we still have a lot of patients that really struggle with this for quite a while. And so I think them having appropriate expectations up front, as well as knowing exactly how to manage it, when to reach out to their care team. Obviously, as you mentioned, making sure that they have loperamide at home are all really important aspects of early patient education. I will say I do tend to see more diarrhea with their morning dose than the evening dose, even when they are eating something beforehand, but especially if they don't. So that's another counseling point I always try to include, is making sure that they're eating breakfast prior to that morning dose to try to limit that diarrhea a little bit. And then I think loperamide is a little bit tricky for people. Everyone responds a little bit differently. And so providing that education up front so that they know how to titrate that dose to what works best for them can really help the tolerability as well. Some people really respond well to loperamide, and I have people that will only need a half a tablet, whereas some people really require a lot more. And so them knowing that it's not the same for every single person and it really is very specific can be very beneficial as well. The other thing that I think is important to think about with diarrhea is this is one where patients will want to adjust things on their own to meet their schedule. So I have some people who will just take loperamide first thing in the morning, then they don't have to worry about experiencing any diarrhea on their way to work or needing to stop. I have some people that it works better for them to just wait until their commute is done to take their dose. Traveling for vacations is tricky. So I think just education around, here are some things that you can try. The most important things is that you're not doing self-directed breaks, that you're really working with your care team to manage this diarrhea in a way that keeps you on the medication but works best for your lifestyle. I think is some other key factors that I take into consideration on initial and follow-up counseling for all of my patients taking abemaciclib. Then I also wanted to kind of just like briefly bring up, we'll review some data a little bit later, but I have a pretty low threshold for dose reductions for diarrhea as well, if it really is problematic for them in their lifestyle. And so that I think is an additional area that we can consider, and we can talk more about in a little bit later on in our discussion as well.
Great points. I think um, as we talk about these medications, we're talking about patients being on these therapies, taking them almost every day for 2 to 3 years, which, we need to work with their lifestyles as well. So I think you bring up some really great points on how to do that, how to work with our patients to ensure they're taking it but still maintaining that good quality of life.
Exactly. One side effect that I think is also really important to touch on with these medications that are used in the early stage setting is the potential QT prolongation that we can see with ribociclib. And so, for this particular adverse event, I do think that even though it doesn't happen super commonly, it is another one that really requires a lot of education up front so that patients understand that they are going to need that EKG 2 weeks in to ensure that QT prolongation is not happening. And then another really important education point with QT prolongation from ribociclib is the new medications. I know we mentioned that earlier with hepatotoxicity, but I think it's really important here too to make sure that patients are aware if they are considering starting any new medications to let the care team know. That way we can ensure that it's safe to do so. And then specifically in regards to their treatment for their breast cancer, another kind of caveat with this is it is contraindicated with tamoxifen. And so if we do have somebody that is really struggling to tolerate aromatase inhibitors, that does limit our flexibility a little bit in their endocrine therapy partner because of this potential QT prolongation that we can see. I'm curious for you, Danielle, the added level of complexity sometimes is with the right QTC. So I'm curious at your center if the QTCF is reported in the EHR, if that's something that you're having to calculate, and what that experience has been like for you.
And we do not get a QTCF as part of our EKG report that's coming through. So it is something that we do need to calculate outside of our EMR. I've found that there are a number of online calculators that are very helpful, but you do need to have some additional information about the patient. So you do need to have their heart rate and be able to input that as well as some information from the EKG into the calculation to get the QTCF. And I think that's probably, I'm guessing there's other institutions that are having to do the same thing. So I think it's just a really important point that is not necessarily the same, and we need to confirm that we're actually calculating or looking at a QTCF as we make any recommendations per the PI. How about you, Jordan?
So ours is a little bit unique in that our EKG machines do have the QTCF, but it doesn't pop up in our EHR. So we either have to go to a different software to find it, or we have to use an online calculator similar to you. So I do a little bit of both, but it's definitely an extra layer of complexity that we have to take into consideration.
Yeah, thank you for so that we just had a lot of discussion on adverse effects, some really important ones. I think a lot that drives back to early principles of patient education and our monitoring strategies, so that we can hopefully keep patients on these therapies that we know are very efficacious in that high risk early stage setting. So we've talked through some of these already, but I do want to have some additional discussion about adherence strategies and so how we can kind of work together as a healthcare team to keep patients on treatment. So we mentioned that there's a lot of complexity happening for these patients. So there's oftentimes with these high-risk patients, they have had chemotherapy, surgery, radiation, they're receiving endocrine therapy, and now we're adding on this targeted agent that we're talking about a long duration of, depending on our drug, if it's abemaciclib, generally 2 years, ribociclib, we're talking 3 years of treatment. So there is a lot of complexity here. And I think one area that requires some discussion is the financial toxicity for our patients. So Jordan, I wonder if you might be able to comment on your experience here and anything that your team is doing to help monitor for this.
Yeah, so usually up front, I try to, prior to the script going out, we usually counsel patients in clinic the day we are planning to send the script. And so I'm able to kind of educate the patient These sometimes can be very expensive. If the pharmacy does call with an unaffordable copay, please let us know. We are fortunate that we do have a health system specialty pharmacy. And so we have a lot of communication back and forth with our specialty pharmacy, which I think is very advantageous. But even without that, I think the patient understanding when to reach out to let us know so that we can potentially find other ways to make this medication affordable, whether that be copay cards or patient assistance programs. These medications all have grants, lots of options available. And so ensuring that the patients know that they may qualify for assistance, but we can't assist with that process if we don't know, right? And so, and then, lots of different care team members are going to be involved, whether that be a social worker, members of the specialty pharmacy team. But I think the most important part is ensuring that the patient knows there is the potential for that high cost to be there. There are options that can make it more affordable so that we don't run into the scenario of them just refusing the medication and no one knowing until the next time they come to clinic, is the kind of like primary avenue that I approach the financial toxicity component.
I have this similar practice as well. That education up front, very important. Frequent touch points with our patients, I think is also really important. And that's even patients that have been on this for the long term. We may have opportunities to space out those touch points for patients that are having great tolerance, but I think still maintaining some sort of regular cadence with a touch point so that you can even talk about things like any anticipated financial toxicity, how to adjust for changes in vacation schedules and things like that. I think all of that is really, really important. Having a team, ideally a team approach to financial toxicity, working with specialty pharmacies. We have a dedicated group of nurses that helps with this process along with our pharmacy colleagues. And I think another challenging time point is that the point where we're getting to the first of the year, where patients may have new insurance plans or the deductible is resetting. And it's often a time point that we need to make sure that patients have, or there's a plan in place for any changes in that financial burden. I do also want to touch on some of the key talking points because we've talked through toxicities and the need for frequent dose holds and dose reductions. And sometimes that can be a really scary thing for our patients. It can also be something as a healthcare provider that we try to avoid, with those dose reductions out of concern for impacting the efficacy, and particularly efficacy maybe in the early stage setting where we're talking about curing the patient. So one of those points I want to bring up is just the fact that we do have some data from both the NATALEE and the Monarch E trial showing that adjusting the dose is success and not failure. So following those protocol guided interruptions and dose reductions to maintain the benefit also helps to keep patients on treatment and isn't impacting the efficacy of the medication. So we have some reassuring data from these trials showing that the benefit of both of these agents is maintained even in the face of dose reductions. So in 4-year invasive disease-free survival with abemaciclib, and also data coming out of NATALEE trial showing that invasive disease-free survival is maintained at landmark analysis, I think is a really important point to share with providers that may have some hesitancy, as well as our patients that may be hesitant to proceed with a dose reduction in this setting. Jordan, I'm curious if you've had the opportunity to share this information in your clinical practice with your patients.
Absolutely. I 100% agree. I think it's not just scary for the healthcare team, it's also scary for a patient to have a dose reduction. And so this data has been extremely helpful in that conversation. I try to incorporate it in my initial education because the last thing I want is for them to stop the medication altogether, especially without us even knowing, which can happen if they are feeling really poorly and we aren't knowing. So, in addition to all the things that we've already talked about as far as educating them and early monitoring and management, I think one of the important things for them to understand is that we do have the option to go down on the dose, and the outcomes are exactly the same. And so if you're not tolerating it, we will try a dose reduction. And a lot of times patients tolerate it much better. And so them knowing upfront that there are potentials to make that dose more tolerable for them can really help with adherence.
I think as we talk about patients wanting to like suck it up and push through, but I think again, talking long term, that we need to get these patients through 2 to 3 years of therapy. And there are strategies we can do to improve their quality of life and to get them through those years. So I think kind of setting the stage up front with some of this information can be really important so that they don't feel like there's any failures in reporting this back to us. In fact, it actually is helpful for us to have this information and hopefully keep them on treatment longer. So I'm curious, Jordan, if you could share just overall any strategies you found are beneficial in patient education, kind of like who's educating your patients, what kind of information is being provided, is it verbal, written, just anything that you found to be helpful, kind of setting the stage as patients start these medications.
Absolutely. So, as I mentioned, we try to counsel everybody in person in clinic the day the script is being sent. And I do find that that provides a lot of value. It's not always possible. Sometimes that education is going to have to be virtual. There's always things that come up that may not make it possible. But I do think that in person education really does provide a lot of benefit to our patients, not just in the level of understanding, but also the level of comfort with the new medication, but also with you and the sharing of potential side effects that may come up later on. And then we also have the benefit of having that health system specialty pharmacy. So even though we provide comprehensive education in person, they do get some reiteration of that education before the script is being dispensed from the pharmacist at the specialty pharmacy as well. And so a lot of times our patients are able to receive that initial education in person, receive written information from us. We typically here at our center use the education sheets that are developed by HOPA, ONS, and CODA. And then they have a chance to kind of read and digest and then get that second education from the pharmacist at the specialty pharmacy. And we found that that really can be quite beneficial for the patient's not only comfort level, but retaining of the information and knowing what to expect as well.
Yeah, I would say similar experience on our end. We prefer in-person visits whenever possible, but do make virtual options available for our patients. I think it's really helpful to have a multidisciplinary approach to education. So patients will often meet with the pharmacist, a nurse, and then sometimes the advanced practice provider is included in those visits. And another strategy that has been really helpful in our practice is providing patients with a calendar. As we think about ribociclib and palbociclib in particular, they need to track weeks on and weeks off. For abemaciclib, it's twice daily dosing. So I think for certain patients, use of a calendar and even kind of check boxes next to the dose for the day can be really helpful to track that information and make sure we're all on the same page. Jordan, any particular strategies you're using for adherence, outside of calendars, anything else that you're routinely doing for these agents or recommending for patients?
I think routines are super important as well. I think calendars are very beneficial. And then, in addition to that, if you can tie in their timing of the day that they are taking their medication with something that's in their regular routine, it's a lot easier for them to remember. And then always kind of providing them with some additional strategies anytime they're outside of their normal routine, like going on vacation and things like that.
Yeah, for some people, cell phone alarms are really helpful. You just really have to
Yeah.
find something that works for the patient and really just making sure that they know that we are a support system with them through all of this, making sure that they know how to contact their team when they need to report that side effect, when they are having issues with financial toxicity, that they have just a important point of outreach with a particular person that they know they can get on the phone or see in clinic, and that they build that relationship with the team. I think that that's invaluable, that as they start these therapies, that they feel supported by the healthcare team, and whoever is that point of contact, whether it be a pharmacist, a nurse, a technician at specialty pharmacy, a provider. I think just making sure that they know they have that support system and we're able to provide that for them is really important.
Absolutely.
Yeah. Well, thank you so much, Jordan. We've covered a lot today. Hopefully, everyone's feeling a little bit more confident about what we're monitoring for and how we might manage these side effects, and really how we just holistically manage these patients as we help to get them through these long courses of treatment. I really appreciate your insights, Jordan, and nice talking with you.
Thank you.
To claim CME credit for this activity, please click on the Claim Credit button on your screen.
Thank you, Danielle and Jordan, for a great discussion and for sharing your expertise with us. And many thanks to you, our listeners, for joining us today. Be sure to check back for more episodes on important oncology topics.